we're doing a bit of a team event. I have to say, there's actually 8 of us, so we are going to be whipping through some of the different roles that I think we're starting to see cropping up in primary care around the personalised care roles. So you'll have an opportunity to hear from colleagues who are working as health and wellbeing coaches, social prescribing link worker, care coordinator, and we've also got colleague Liz Reader, who's a practice care coordinator, who has, as we like to say, well, we don't like to say because we don't like the word, but she's been on a journey around personalisation, so she's just going to share her story with you. Am I able to share my screen, Susan? I don't know, I haven't tried. Let me just check. I think I can. No, I'm just fab. So I've literally just got 2 slides to share with you. First thing to note is that we launched a website back in September called It's All About People, and we'll put the website address in the chat for you. It's a space where we've developed a space for the workforce across Lincolnshire health and care system to go to really start to understand what's going on in the Personalisation Programme, and to explore different parts of the work that we're doing. But it's also a place to really showcase some of the work that's going on across the county. And you know, we've got video clips and case studies and so on from colleagues from across our system. So again, we're really keen in primary care to work with primary care to start to showcase some of the great work that's going on in your world as well, and to look at ways in which we can promote that through the website. And we do have a direct link to the Training Hub website through ours, and vice versa. So we are making those connections. Just really want to talk to you briefly about what is personalised care and what our aim is in Lincolnshire. So our key aim is to shift that relationship and the conversations between people and professionals and our health and care system to one which focuses on their strengths and assets, what matters to them, and providing that positive shift in power and decision making that enables people and those who are important to them to be able to live their best life. And I think we would all agree that that is the way that we need to go. This does mean and does create a sort of an evolution, if you like, of the caring landscape, moving away from that more the sort of professional practitioner role as being the fixer and somebody that's going to sort stuff out for people, to actually becoming an enabler and working with people. I think we have a real challenge in terms of how we work with our patients, our clients, the people, from being passive recipients of care to actually becoming active participants. And that's where we really want to focus in terms of the Personalised Care Programme, is how do we work with our professionals and the people that we support so that they have much more informed conversations, shared decision making happening across the piece, and people have got much more choice and control. The system, as we know and currently very much know, operates in a very reactive way. So how do we move from reactive to proactive, preventative, personalised ways of working with people? And how do we shift our approach from a deficit, so what's wrong with people, to focusing on an asset-based, what's strong in people? And again, I think that's a fundamental shift for some of our workforce, and we really need to explore that and understand how we have different conversations with people. That needs to be driven through data, through information, through, in some cases, digital solutions, but really starting to think about that self-care, self-management approach and that change in mindset in terms of the conversations that we're having with people. So more of a coaching, strengths-based conversation and focusing on quality improvement. We've got 5 priorities that we're working on in Lincolnshire at the moment. Top one is, as probably no surprise, is around culture and behaviour change. So that focusing on strength-based, person-centred approaches, personalised care and support planning, which is part of the DES contract for primary care into next year, and then social prescribing community connections, which again is part of the DES contract. We're also doing some work in Lincoln County around embedding strength-based, person-centred conversations into discharge, and we've got a big piece of work that we're doing around communication and marketing. So I will just plug the website again. It's all about people. I will now hand over. So we're going to do a bit of a relay. So I'm handing over to my colleague Liz Reader, who is a practice care coordinator. She'll introduce herself and she'll tell you her story about personalised care.
Hello, I'm Liz Reader, practice care coordinator at Vine Street Surgery in Grantham. I've been district nurse since '96, so I've worked locally in Lincolnshire for a long time. About 4 years ago, I was asked to attend a 4-day course, a Helen Sanderson personalisation course. It meant me travelling to Spalding, so about a 45-minute journey each way. And I just thought, you know, I'm really busy, I haven't really got time for this. So I attended day one, and after day one, after spending day talking about that we need to focus on asking patients what they want and how I can facilitate what they want, I just thought, I haven't really got time for this. I thought that if I really ask patients what they really want, I felt that the answers were going to be unrealistic, and with limited resources, I just felt that I was almost setting myself and patients up to fail. So I really struggled with that concept, so much so that I decided I wasn't going to go back and complete the training. So I walked out after day one and just thought, I've got such a busy caseload, I can't imagine spending more time asking people about things that I didn't feel were realistic. Moving on my journey, so to speak, I read more up about personalisation. I did more short courses, and then I started to get on board with, actually, if I really sit down and think about you know, what patients want, then perhaps I might get a better outcome with some of my complex patients that we've tried to work with over the months and years and not really got anywhere. So, you know, the pennies started to drop. I only drink green tea with lemon, whereas my husband likes his traditional with milk and sugar. So, you know, if we look at what is our choice of drink, mine and my husband is very different. So then why should healthcare be any different? So I have tried to work in a more personalised way moving forward, and have seen the benefits for patients, for myself, for families. So much so that I now, whenever I meet a new patient, I do try to ask them about what they would like from me, what matters to them most, how can I support and help. And in the past, I've always thought people would be unrealistic about what they're asking me to do for them. But generally, I find that patients themselves aren't stupid. They ask for really realistic, really simple things that actually, it's the simple things that make so much more difference to their life. I've got an example that happened a good few months ago when a home visit came in. District nurse has been visiting an elderly gentleman, 94, lives at home on his own. They were doing regular wound care, checked his obs, and he was bradycardic. His pulse was very slow. They called the GP for a home visit, and I was asked to go and assess this chap. I sat down and started chatting to him, and yes, his pulse was very slow, but I asked him what he wanted me to do to support him. His main problem was his bowels. He was really constipated. I explained the concerns about his slow heart rate and the possible consequences if he didn't seek treatment. He'd had enough of hospitals. He was in and out previously, didn't want to go back anymore. He was 94, wanted to stay at home, but what was most important to him was he was on iron tablets to sort out his bowels. So we had a discussion about his medication and sorted out his bowel regime and his diet. and we agreed that I would speak to his family about his wishes about not going into hospital for treatment and investigation for his heart rate. And 6 months on, he's still with us. He's still relieved that, you know, somebody listened to him. The family are pleased that he's not rushed, you know, in and out of hospital for further surgery or pacemaker, or and actually that we've spent time listening and supporting him with his wishes. So, you know, I think from that case alone, it just shows you that if we had not really sat down and listened to him, we would have referred him to cardiology, and we would have perhaps sent him in against his wishes, and that's not really what he wanted at the end of the day. So moving forward, it's hard for me now to believe that I would ever go back to assuming I know what patients want, because at the end of the day, they're the only ones that can tell us what they really want. Thank you.
Thanks, Liz. I think we're now handing over to Lisa Dean, who has got a couple of roles actually, but she's going to talk to you about the PCN ambassador role. I think that's right, Lisa?
Yeah, morning everyone. I'm standing in this morning for Claire Evans, who is the Primary Care Network Advisor for the Midlands area. So this is her presentation, so I might read it a little bit, if that's okay. Sharing always helps. Can everyone see that okay? Can somebody just say yay? Yeah, cool. Okay, so this is like I say, this is Claire's presentation, so I do apologise if I kind of read it just a little bit, because I kind of got this at last minute. So Claire's the Primary Care Network Advisor for the Midlands, and she can support PCNs looking at the 3 roles and the implementation of those 3 roles. So we've obviously got the social prescribers, link workers, health and wellbeing coaches, and your care coordinators. The roles that are part of the integrated system, and in a sorry, I'm going to start again. So yeah, the 3 personal care roles that are being highlighted are to support individuals to effectively navigate the system both externally and within the community, and to build the personal resources that are needed to self-manage and live a healthy and fulfilling life. And these roles, when integrated into the system in a considered way, reduce the workload of traditional primary care staff and increase take-up of wider support, and reduce duplication, hopefully, and improve efficiency and experience for the patient going through the healthcare system. Importantly, these roles can contribute to the reduction in health inequalities, levelling sort of the playing field, giving targeted support to those who need it most. Most areas will have access to social prescribing link worker. Obviously, they've been in post since July 2019. And the 2 other roles, the care coordinator and the health and wellbeing coaches, have come in April 2020. There can a skill mix across those 3 roles, but actually they all link really well together, and they offer a kind of a complete package for patients and individuals. So that's that part. I'm sure everybody's seen this infographic a few times now, kind of just giving a brief overview of the 3 roles and of the areas that they work in. The care coordinator, you know, it's very much around the patient, their needs, helping and supporting them navigate through the healthcare system, and sort of have those conversations of what's important to them, around their health within the clinical care system. The social prescriber, the wider determinants, so things like housing, debt, stress, loneliness. They work collaboratively with partners across the community of where those people live and work, and offer sort of practical and emotional support. Health and wellbeing coaches tend more behaviour change, looking at the individual of where that individual wants to go, improve their own knowledge and skills and confidence around their own health and well-being, to make those choices of how they want to live a healthier life, and to sort of reflect on how some health-related behaviours can have an impact on their health and well-being, and support them to identify that through goal setting. Going to move because I'm conscious of time. I'll share these slides because this slide might be useful for people. It's got all of the contact details of all of the Midlands regional support roles. I'm the health and wellbeing coach mentor for the Midlands, so I cover the whole of the Midlands and support health and wellbeing coaches. And then we've got a mentor for the care coordinator role, and I think for the East it's Maria, who's the social prescribing link worker, and Claire, like I say, is the primary care network advisor. Claire has asked me to make everybody aware of a session that she's doing where she'll do the full presentation of what would have been done this morning, and that's on the 10th of November at 12 o'clock. There's a link on here if you haven't seen it already to email and enroll on it. Like I say, I'll pop the link in the chat, and I'll also share the slides so you can have access to that and have the professional full delivery of this webinar. So but that's the regional side of it. Thank you.
Thank you. Is it over to me now?
Yes, it's over to you, Jo. Sorry, my mute got stuck.
Right, thank you. Hi everyone, I'm Joanne Yeomans. I work as a care coordinator in South West Lincolnshire. I've been working with the neighbourhood team since 2016. I'm one of 7 non-clinical care coordinators working in our area. Our work begins with a nomination being received to the neighbourhood team, either directly from the GP practice or from wider organisations, with the consent of the person or through best interest. Those nominated to the neighbourhood team can often have complex health and social needs and are over the age of 18. Our role will start with initial information gathering. This might include a telephone call or a visit to the person and their family, as well as reviewing information on our clinical systems and which other services agencies are involved. That will then be fed back to the neighbourhood team at a multiple steps. Care coordinators can act as a central point of contact for those nominated and their family carers to the neighbourhood teams, as well as to teams and workers, and can support with signposting and care and support planning. This may be based on an initial conversation or a personalised care and support plan. The method and approach used is what works best for the person. We can discuss what matters to them and look at what action support is needed to help meet identified goals. This may require onward referral, for example, to social prescribing. I thought it might be helpful today to share an anonymised example with you regarding someone who was raised to the neighbourhood team and the role that we played in supporting from care coordination. So for the purpose of today, known as Mr. Brown, Mr. Brown was raised to the neighbourhood team by United Lincolnshire Hospitals due to frequent admissions with prolonged length of stay. The initial role for myself was to contact the GP practice to advise of the nomination and discuss any thoughts they might have on what support may be needed. I arranged a home visit to meet Mr. Brown to better understand his situation and what mattered to him. At the visit, he advised he was struggling with loneliness as due to his health, he was no longer able to work and had gradually stopped attending activities he used to enjoy. Due to the complexity of his rare medical condition, Mr. Brown was likely to continue to need acute medical support. So a personalised care and support plan was completed in order to support a timely discharge process and share what was important to him. This was important for Mr. Brown in order to feel listened to, as he said he often felt unheard by health professionals. One of his identified goals was to start going back to the groups he used to enjoy, and a social prescribing referral was made to support with this and review any wider concerns that might impact, such as finances. It was arranged for Mr. Brown to have specialist support to better understand and manage his medical condition, and for community therapy support to review. As a result of the nomination, he now has a plan in place for supporting discharge and aiding professionals in better understanding his condition and circumstances. This is reinforced with myself or a colleague contacting the hospital when he is admitted to highlight the plan on Care Portal and neighbourhood team involvement. This has resulted in swifter discharge, and he has now returned to activities he used to enjoy, such as swimming, as well as attending new groups. Mr. Brown feels more confident in managing his health and knowing when and where to seek support, and has said he feels more empowered in conversations with health professionals. Thank you very much for your time. I'd like to hand over to Annette now to discuss the role of the Health and Wellbeing Coach.
Thank you. Hiya. I'm sorry about my voice, it's coming and going today, so I'm going to try my best. My name is Annette Harding. I'm a Health and Wellbeing Coach for South Lincolnshire. I've been in post for just over a year now, and I'm really excited to be able to share with you the value of this role, as it's a new one. I cover all 7 GP practices in South Lincoln, which covers approximately a 50,000 patient population. As you can imagine, that's quite a task. With this being one of the new R roles, the main challenge has been the education to the wider healthcare profession about what is my remit and my role. There's been a lot of confusion over what I can and will offer and how that will be delivered, and the expectations of what I can deliver and within what timeframes, and what exactly the benefit of my role would be to the patient, but also importantly to the PCN and practice staff. So to give you an overview of my role, I've put together a quick case study, which will hopefully showcase where the Health and Wellbeing Coach can make a difference, how it makes a difference, and what that has meant to the patient, the GP practice and wider PCN. So this chap, who is 76 years old, type 1 diabetic, fortunately, recently widowed. He'd moved into assisted living due to his mobility issues with his glaucoma and neuropathy. He's self-managed his diabetes independently from his 40s, successfully keeping his blood sugars within a tight range, diet managed well, had a good level of understanding of how to self-manage his condition previously. He was not symptomatic in his hypos or hypers, so managed his testing with the use of a Libra monitor and self-adjusted his insulin accordingly. 2 things then happened. Sadly and tragically, his wife had a fall at home and died after hitting her head on the living room unit. The trauma of this, watching his wife die to this day, is still present, and the impact of that is still being felt. The second thing was that his Libra monitor malfunctioned, advising him that he was having hypo, so accordingly, as he'd normally do, used glucogel and sugar drinks to raise his BMs. He repeatedly tested again and again. His monitor couldn't get his BM up, so he called 111. He was admitted. He had consumed so much sugar, he was then in a hyper state. The panic and confusion and loss all presented together whilst he was in hospital, and he was suspected of lacking capacity. Although no more formal test was undertaken, the decision was made for him to manage his insulins for him. His insulin regime was changed. He was sent home with the district nurse team calling twice daily to administer his insulins. This is a complete change for him. This led to him feeling completely out of control, frustrated, angry, and became very volatile. He felt a prisoner within his own home. He was having to be at home so much, waiting for his insulins to be administered. He was constantly phoning the GP, nursing team, adult social care, 111, anyone he could get to listen, but his story was very confused and chaotic. At this point, he was referred to me. The first thing that I did was sat and listen to him, let him elicit his story. The value of being and feeling heard is so powerful and makes such a difference to the patient. What was important to him? What did he feel he wanted to work on? How did he see his future? What did that look like to him? What needed to happen for that to become true? We then together made a personalised care plan, his thoughts, feelings, wishes and goals. This gave him time to reflect on his recent behaviours and short temper and really concentrate on what he felt he could control. His main goal was getting back to having control over his diabetes and general health, get back to living his life, going back to his hobbies and feeling more at peace with everything. He made another goal of learning about his new insulin regime and how he could re-educate himself about the mode of action in his diet, how he could change that to help himself. Through these coaching conversations that we had, he decided that looking for diets on Diabetes UK would be helpful, which he did independently, and we discussed what he'd learned. We then discussed what he had researched and how he was going to implement that and what support he might need for that to happen. He wanted the opportunity to discuss his diabetes with the type 1 team to gain clarity over what had happened to him and get plans in place to manage his diabetes going forward. I then linked in with our care coordinator and she gained an appointment for him, which I accompanied him with his set of questions that we'd compiled together through a coaching conversation that he wanted answers to. It was not something that he could request as a referral, otherwise I would have coached him to do it himself, but it was something that had to come from a healthcare professional. I linked him with adult social care and he gained assistance with his weekly laundry, which he was struggling with due to his glaucoma and mobility. A referral went to Wellbeing to assist with some debt since his wife passed and struggled with his vision to go online and keep up to date with everything. We discussed his mental health, and after a coaching conversation, he felt the need to make contact with his GP and antidepressants were prescribed. He declined counselling at this point, but happy to revisit at a later date. He's now linked into social prescribing to help him support him integrate into his life as a widow and not to become socially isolated. He's now back in control of his insulins, feels empowered by having his care plan and actions agreed with a time frame so that he can share this openly with any other healthcare professional. He does not have to keep retelling his story and can focus on the changes he wants to make and gain access to the information he needs to keep himself well. All of the progress was self-led, worked with and not done to. This is what we do as health coaches. We empower the person to take ownership of their health and situation, and by coaching and using motivational interviewing, planning and working towards their goals, allow the patient to focus on what they can do and what's important to them. The other roles that were involved in his care were the OT assessed for falls and mobility and discussion with our mental health practitioner for his decline in mood. The impact on his GP practice and PCN is reduced calls. Calls are now appropriate. There's a reduction in calls to 111. Again, they're now appropriate. The patient now has the skills and techniques and support in place to allow him to be in control over his own health, and the long-term effect of that for GP practice and PCN is a positive one. So hopefully that's a little sort of snapshot of what I do. So I'm going to hand over to Amanda to talk about the social prescribing. Thank you.
Thanks, Annette. Oh, sorry, pulling my headphones out. I've got a little bit written down, if everyone can bear with me, because I'm not amazing at this kind of thing. But my name's Amanda. I've been a social prescribing link worker in Boston since the proof of concept phase back in December 2018. It's been quite a journey. We've done a lot of engagement and trying to showcase what we do and how we do it and all of that kind of thing. But basically, I feel like as a link worker, I use community resources to support the health and well-being of participants who are referred into our service. This is people over the age of 18, and they're often referred in for a variety of reasons. Annette's just said about a gentleman who'd been bereaved. Things like bereavement, social isolation, loneliness, and lower level anxiety and depression are just some of the reasons we get people coming to our services. Sometimes people self-refer in. They might have heard through somebody, whether it's a medical practitioner or family or friend, about social prescribing, or we take referrals from other practitioners within the wider neighbourhood team and our local GP surgeries. We start by having what we call a triage call with our participants, and that's like the initial point of contact with the link worker and the client. And we explain what we do to people, and then we take a little bit of time and listen, to where they're at and what sort of things has led up to the referral and why they feel like they might need social prescribing as a service. I feel like it's important to understand some of the underlying causes of somebody's situation, because it then helps us unpick barriers and it helps us to find a positive for them to have that starting point to move forwards. I find it really important to listen to our participants, because if they've got problems which have led to multiple GP attendances or lots of other clinical appointments in different ways, and they still feel like they're not getting anywhere, they can have this feeling that people just haven't got time for them and they're just not important enough to listen to. So us taking that time, it removes a big barrier and it makes them feel a lot more trusting, and that they can open up and tell us the things what are wrong with them. when I talk to our clients, I always describe social prescribing as the pink fluffy service. It tends to make people smile a little bit and makes lighter of sometimes a more unpleasant conversation. But I explain that we're not there to meet any of the basic needs of the person. We're not meeting the health needs or the care needs. We're addressing the social side of their life, which is ultimately impacting on their health and the well-being. And by getting them to think about what's important to them, to what makes them feel good and what makes them feel happy, we can then help them to identify achievable goals, and we can work with them to achieve those goals. I work within the third sector, and I have a lot of close links with different community groups and organisations and things like that, and that really helps me in knowing what is available within the communities and how we can support people within the communities to enhance the things that they've got and just to improve things. I could literally talk for ages about why I feel like social prescribing is good and why it works and all of that kind of thing. But I thought I'd wrap it up with a little bit of a case study for somebody I've worked with in the past. Anne was happy for me to share her story because she feels so much better nowadays. She self-referred into social prescribing through hearing about it through a family friend. And that was not long after she was widowed. She was feeling really lonely and isolated, you know, being in the bungalow by herself. Her mood was low. She'd had a stroke a couple of years before, which she still felt her mobility was reduced, and she was fearful of falling, and she'd got no self-confidence or anything like that. After listening to Anne and observing her in her own environment and just taking in the bigger picture of what was going on and encouraging her to think and talk about the positive things that she might have tried before or really wanted to try, or why she felt that things were limited and what barriers she felt that she'd got. We were able to work together and identify different things, and we were able to set some goals. I found a local Qigong group, which was within walking distance of her home. We initially attended this together as she didn't quite feel confident enough to be able to start something new like that by herself. So we went along to that a few times, and she enjoyed it enough to want to keep going back, which she very soon did without me being with her. In the meantime, I'd also identified a local art and craft group. I thought this was appropriate because as I was in her home through different appointments, I was noticing all this homemade artwork and paintings and different things. And she'd chatted about the different points in her life where she'd done this painting or done that painting. So she was really quite enthusiastic about the art group, and she felt more able to start that by herself. And so I never went with her to that. And she soon began talking about volunteering and wanting to give something back. Through talking and listening to her, I found out that she'd been a foster parent for many years, and from her retirement she'd felt this huge sense of loss of purpose and not knowing what to do with herself or anything. So I connected her into a few potential volunteering opportunities, and she went through those herself and chose one and later began and started in this role. At review point of working with her, Anne stated that she no longer felt isolated. Her mood had noticeably lifted. People were commenting that she seemed happier and more like her old self. She felt more confident. She had begun to volunteer, and she said she'd got an increased sense of purpose. She felt things were worthwhile. She'd been going regularly to the Qigong classes. That had overall improved her physical health. Her mobility was so much better. She felt much less fearful of falling, and she just overall felt more confident. And the enjoyment she'd got from going along to the art classes alongside of this had just made her feel overall more happy. And she just stated at the end of it that her overall physical and emotional health had improved. She was overall less anxious about falling. She said she was much less likely to be able to go to a GP for any reason. She genuinely felt more empowered to know where to go to ask for help in the future. And she said she felt more in control of her own health and well-being. And like I said, Anne was quite happy for me to share that story. And it's one of the nice pinker, fluffier ones that I call it for our social prescribing. And it's such the little things that we've done, but it's made such an overall impact on her life. And there's been quite a lot of people like Anne throughout the whole of the county since December 2018, when I had my very first participant. And hopefully there'll be a lot more like her who we can go on helping in different ways as well. That's everything I've got to say from me. Thank you.
Thanks, Amanda. And now we're just going to hand back to Annette, and we're nearly done. Annette and then Emma.
Yeah, nearly done. I'll get through it as best as I can. Right, so just going to give you a quick overview of the Personalised Care Institute and my ambassador role within that. So a little bit about the Personalised Care Institute nationwide, really, and then over to Emma for the local things. As part of the NHS long-term plan to deliver personalised care to 2.5 million people living in the UK by 2023-24, the specialist roles that we've heard about today that have been created to help people access the support and advice they need. We all know that the thought of embedding personalised care within our day-to-day conversations, frameworks, policies and procedures can feel daunting for most of us, really. But with 40% of patients saying they would like to be more involved in decisions about the management of their healthcare, it's absolutely clear that all of us in the health and care industry need to consider our approach. Personalised care requires all of us to refocus from what's the matter with someone to what matters to someone, the with me, not without me. It improves health, quality of life and a blending of care by allowing individuals to take on as much responsibility as they want for managing their own health without ever feeling left on their own. How is this all going to happen? It's going to take all of us. However, through the implementation of the new R's roles, we have a dedicated team to support each other. As you've heard, we have the care coordinators, and their primary role is to support the multidisciplinary teams to bring together multiple services around a person to ensure their individual needs are addressed through a single personalised care and support plan. The health and wellbeing coaches using health coaching skills to establish a one-to-one partnership with individuals in their care in order to improve levels of patient activation. And the social prescribing link workers taking an holistic view of people's health and well-being to deliver non-medical care by connecting them with partners, services, community groups and local voluntary organisations that provide people with a sense of purpose and belonging. So the home of personalised care education at a national level on the PCI website are equipping health and care professionals with the knowledge, skills and confidence to help patients get more involved in decisions about their care. And evidence shows that this leads to better health outcomes and increased patient and clinician satisfaction. So the patients are treated as a whole person by professionals that they trust, are involved in decisions about their health and care, are supported to manage their own health and wellbeing through health coaching, access to self-management programs and peer-to-peer support in the community, and feel their care is coordinated. The impact and evidence behind this approach, there are many. One example of this, there are many more on the PCI website, is recent research from the Health Foundation monitoring 9,000 people with long-term conditions. The outcome of this was that people who feel confident to manage their health have 18% fewer GP contacts and 38% fewer emergency admissions than people with less confidence. So this research is significant in showing how the effective delivery of personalised care can reduce the avoidable use of health services and improve patient lives. The national training offer on the PCM website is comprehensive, so Emma's going to put a link in at the end of this presentation. But some of those are core skills, shared decision making, the personalised care and support planning. There is a separate module for the personalised care and support planning for maternity. So with all that said, the PCI have launched a brand new ambassador programme, which is made up of 20 of us, qualified, skilled and passionate professionals from across a range of specialisms, including GPs, nurses, midwives, physiotherapists, social prescribing link workers, health and wellbeing coaches, OTs and a host of other health and care roles. And as an ambassador, I will be working to keep personalised care high on the agenda of professionals across the health and care sector and to inspire them to start their personalised journey, care training journey. Inspiring our peers to learn more about personalised care so they can empower their patients to have more control over the treatment and improve health outcomes, to have those coaching conversations. And we know that personalised care and switching the focus from what's the matter with you to what matters to you leads to better patient outcomes, the with me, not without me. And I'm very excited for what we can achieve together. And as the ambassador for Lincolnshire, I'm more than happy to help and guide wherever I can. Emma's going to have the links to the PCO website and the information about my ambassador role and my contact details in the chat. So thank you for listening, and I'll hand you over to Emma.
Fantastic. Thank you very much, Annette. So hello, my name's Emma Townend and I'm the Personalisation Project Manager working across the ICS with Kirstine. You'll be pleased to know I only have a couple of slides and I'm just going to talk you through, I suppose, some of the local training offers that we have for you in in Lincolnshire currently. So the first one is coaching for health and wellbeing. So coaching for health and wellbeing is the use of skillful conversation to actively engage people in health behaviour change. So TPC Health have been funded by the Lincolnshire ICS to deliver coaching for health and wellbeing. So far, we've 160 practitioners have been on the PCI, so Personalised Care Institute accredited training by TPC Health. And the feedback has been really positive. In fact, it's been more than positive. It's been fantastic. So, you know, practitioners are talking to us and telling us, you know, that they've moved from being kind of fixers to really enablers. And they're getting people to find their own solutions, making their own plans and following through with the plans and making positive changes to their lives. So the next cohorts for the coaching for health and wellbeing we have are in January and March. So the January one is open to any practitioner in Lincolnshire who's patient facing, and the March one we have specifically ring fenced for primary care. And again, that's anybody in primary care. You know, it doesn't have to be clinical, but they just need to be patient facing. The places for this course are fully funded. And consist of 4 half-day virtual sessions, and then there is another half-day CPD session about 3 months later. So the second offer we have is personalised care and support planning. So everyone that's they're a local organisation in Lincolnshire, so we funded them to deliver a virtual programme in personalised care and support planning. And some of the things, so this isn't an extensive list, this is just a few of the things that it will cover, are things like the importance of knowing what matters to people, one-page profiles, personalised care and support plans, shared decision making, a message in a bottle. The programme is in the process of being Personalised Care Institute accredited, so we're hoping that that won't take too long. It's fully funded and is open again to any practitioners in Lincolnshire who are patient facing. And this is run over, so this programme is run over a series of weeks in bite-sized sessions. So what they get is they get 4 2-hour input sessions and then 4 1.5-hour reflective discussion sessions. So we can, so I can make sure that details of both of these courses are sent to everyone on the webinar. So I'll get the details over to Ruth and she can hopefully get them out. And that's it really. And then just finally, you know, you've heard from lots of us today, some really, you know, hopefully you've found it enjoyable. So over to you really, just, you know, if you have any questions for any of us, please feel free to drop it in the chat or just shout out, or you could be super polite and raise your hand. But thank you very much to listening to us. Thank you. So don't be shy, please ask away.
I think it was probably so informative that there's no questions, because there was so many of you, you know, really informed us all about all the different aspects, and I think having all the different PCN and practice input was brilliant. So thank you so much, Kirsty, Emma and extensive team, for coming to speak to us today. I know that the training has been really, really well received, and we will obviously continue to promote that together to get as many as possible. I think, you know, we really appreciate having that that cohort specifically for primary care, but obviously there's the earlier one as well, isn't there? So just to let everybody know regarding the rest of the day, we're having a break now until 1 o'clock. 1 o'clock till 2 o'clock is the care programme. The engagement for the care programme is starting. It's on a different link. We're just going to pop the details into the chat box here, and then we're back on this link later this afternoon to discuss furthermore about the training offer and the upskilling opportunities that are available to you. So we'll be back on this link then at 2 o'clock. So just to thank everybody again for the time. We do have recordings available and we'll put them on the Training Hub website so that everybody has access to those as well. So thanks a lot for your time, and we'll hope to see you later on today.
Thank you.